Our next topic is multiple gestation. Here's our case. A 21-year-old prima gravida at 15 weeks gestation is seen for routine prenatal care. She's 15 weeks. 4 weeks ago, her uterus was appropriate for size and dates. Today, her uterine fundus is palpable at the umbilicus. What is the gestational age, normally, of a uterus palpable at the umbilicus? 20 weeks. She is 15 weeks. And we know she's 15 weeks because we saw her before. Uterus larger than dates. One of the main differential diagnoses is multiple gestation. Let's look at multiple pregnancy. This is what we're going to be discussing. The diagnosis of multiple gestation clinically is suggested by a fundal height greater than it should be, alpha-fetoprotein level which is higher than it should be, HCG level which is higher than it should be. The definitive diagnosis is based upon ultrasound. We can look at gestation, multiple gestation, and classify according to zygosity, chorionicity, amnionicity. If the genders are different, we know it's got to be dizygotic, dichorionic, diamnionic, the lowest risk of all twins. If we don't know what the genders are, or if they're the same, we look to see how many placentas there are. If there are two placentas, it could be either dizygotic or monozygotic. If it is monozygotic, dichorionic, diamniotic, the separation occurred between conception and day 3. And the common complications of any twins is anemia, preeclampsia, preterm delivery, 50% cesarean, postpartum hemorrhage. What if there is only one placenta? Then we look to see how many sacs there are. If there is a septum present, if there's 2 sacs, it's going to be monozygotic, monochorionic, diamniotic, and there the separation occurred day 4 to 8. One of the unique complications that this pregnancy can experience is twin-twin transfusion syndrome. If there is no separation between the sacs, septum is absent, only 1 sac, that is monozygotic, monochorionic, monoamniotic, and there the separation was attempted between day 9 to 12. The unique complication here is cord entanglement. The method of delivery, if both are cephalic presentation, vaginal. If the first one is non-cephalic, which means either transverse lie or breech, it's going to be a cesarean. The diagnosis is based upon ultrasound. If you're presented with this ultrasound on the exam, you're not going to miss it. Twins. Twins can be either dizygotic or monozygotic. If they are dizygotic, they could be the same or different genders. If they are monozygotic, they must be the same gender. And here we see 2 of the same gender. Here we see 2 of different genders, dizygotic. Monozygotic must always be the same gender. This is a patient who came in 400 pounds, in labor, baby is breech. Very difficult to look in the uterus because of her weight. Took her back to the cesarean room, opened up the uterus, took out the baby, reached in for the placenta, and guess what? A second twin, undiagnosed. Fortunately, that doesn't happen very often today with our use of ultrasound. This is a fascinating case that I had, that I reported some years ago. This was a triplet pregnancy, which the mom went into labor at 16 weeks and delivered one of the triplets. I thought it was over, and she'd lose the other ones as well. However, the cervix closed, the contractions went away. We kept her in the hospital for a few days. She said, "Can I go home?" I said, "Sure." She came back 74 days later at 27 weeks, delivered the other 2 twins, and here they are, beautiful young women. That's unusual, to deliver one and to keep the other ones in. I've had the opportunity of dealing with a lot of conjoined twins. This was an article that I published on that. There are many different kinds of conjoined twins. The most common is joined at the chest. And these babies unfortunately had a single complex heart, could not be separated. These babies were joined at the head, and they were separated after a series of neurosurgical procedures. This is the famous Ing and Eng twins. This is where the Siamese twin terminology came from. They were actually joined by a skin bridge. They could have been separated, but they married different women, had children of their own, and lived quite successful lives. This was one of the wildest cases I had, a cephalothorapagus pregnancy. A single head, two bodies. Here you can see the fused ears on the back. This was a non-viable pregnancy. We induced labor, and she delivered double footling breech, 4 feet coming out at the same time. This is the ultrasound showing the single head and two spines. And here is a total body x-ray. Head, two spines. Very unusual. This is a 17-year-old woman who came in, 3 gestational sacs. She needed triplets like she needed a hole in the head. Babies turned out pretty well, however. 3 babies. Triple the blessing, triple the joys. We introduce our baby boys, and here they are. This woman comes in more excited, and she has 1, 2, 3, 4 sacs. My heart went broomph. Instead of thinking of bouncing babies, I thought of cerebral palsy, mental retardation, blindness, deafness, prematurity. Actually, the kids turned out pretty well. This is Jarrett, and he's totally deaf, but otherwise, babies turned out pretty good. This, to me, is a crime. Should never happen. 5 babies. The morbidity and mortality with each additional baby is really high. If you look at the risk of cerebral palsy in at least one child, with twins, it's 1.5%. With triplets, it's 8%. With quadruplets, it's 43%. And the super multiples, it's even higher. We need to prevent these super multiple pregnancies. This is the highest number of fetuses in a human body, 15, according to Guinness World Book of Records. I would be totally embarrassed if I was a doctor that supervised this case. The most surviving children, 7. How do you think they did? Not very well. If we look at multiple births in the United States, the total births is around 4 million. We should have about 40,000 twins. We actually have 110,000, 2.5 times more than we'd expect. Triplets are 14 times more common than we'd expect. Quadruplets over 100 times more common. Why do we see these super multiples? Because of artificial reproduction. And we are shooting ourselves in the foot. When you put in 2 or 3 embryos, we underestimate the likelihood of one of those splitting, and you may have more than you ever imagined with artificial reproduction. Many of the experts now say, don't put in all these embryos. Put 1, at the most 2. Is it time to limit IVF transfers? And I think it is. The current recommendations are, if she is less than 35, put 1, no more than 2. If she's 35 to 37, 2, no more than 3. And as she gets older, of course, the likelihood of them taking is less, and it's probably appropriate to put in more. But in Europe, for instance, in England, by law, physicians cannot put in more than 2 embryos. And I think we're time for that in the United States as well. Look at this woman in Los Angeles. After delivering triplets 3 years ago, she thought she was done having babies. She was wrong. The next pregnancy, quadruplets. Unbelievable. Here's a woman who has 16 children and wants more. I tell you, everybody has their own priorities. All right, what is the most common zygosity with twins? Dizygous. 2/3 are from 2 eggs. The commonest risk factor is ovulation induction. Clomiphene will give you 10% of multiple gestation, and human menopause gonadotropin up to 30%. Significant. And the diagnosis, of course, is based upon ultrasound. If you see this on the exam, you've got it. If there are different genders, they must be dizygotic. This looks at twinning rates internationally. And you see the highest is green. What country in the world is that? Nigeria. Interesting. The lowest is in the bright green, which is Japan. Not entirely clear why. Vanishing twin syndrome is quite common. If you see an early twin pregnancy with 2 gestational sacs, next time she comes back, what you may very well see is one of the sacs is empty. I suspect that there is more of these than we ever think that there is. Empty sac. And if one twin is lost, it does lead to poor obstetrical outcomes in the remaining twin. And here you can see is the little sac with the vanishing twin, which is attached to the placenta. Complications of twins. Antepartum anemia. These are 2 babies drawing nutritional stores from the mother, iron and folate. So that's something we need to be concerned with. Preeclampsia, hypertension, is 3 times more common with twins. Intrapartum complications. 50% will deliver before 36 weeks. 50% will be other than both head down, which results then in a 50% cesarean delivery rate. And postpartum, because of the overdistended uterus, you always need to be concerned about postpartum hemorrhage. So twins are not routine. They are high-risk pregnancies. When we look at the mean gestational age at delivery, with a single fetus, 40 weeks. With twins, 36 weeks. And you can see each additional fetus that you add to the uterus, we are reducing the gestational age by 3 to 4 weeks. Iatrogenic prematurity. Looking at our classification by zygosity, chorionicity, and amnionicity. Zygosity refers to how many eggs. 1, identical. 2, fraternal. Zygosity. Chorionicity refers to how many placentas there are. You can see clearly on this picture there are 2 placentas. Now in ultrasound, this would appear to be 1 placenta, but there are actually 2 placentas which are side by side, which are fused. Notice the number of layers in the intratwin membrane when you have a dichorionic placentation. There are 4 layers. If it is a monochorionic, you typically will have 2 layers, and these are the amnions. So we have 2 chorions, 2 amnions, which make 4, a thick intratwin membrane. Here you can see a thick intratwin membrane, very easy to see. Here is a thick intratwin membrane, 1 placenta here, another placenta here. When we look at the placenta after, we can separate the 4 layers, 1, 2, 3, and 4. And you can see very clearly it's a thick fused membrane. Amnionicity refers to how many sacs there are. Here we have 2 sacs, single placenta. Here we have only 1 sac, single placenta. Notice these are 2 amnions, a thin intratwin membrane, diamniotic, monoamniotic. You can barely see this membrane. It is thin because there are only 2 layers in it. This pregnancy, there is no membrane between. This is a monoamniotic. And remember, if it's monoamniotic, it's got to be monochorionic. If it's monochorionic, it's going to be monozygotic. So this is your triple mono pregnancy. We can look at the classification of twinning by the time of splitting, post-conception. If the separation occurs between conception and day 3, this is all monozygotic. it is going to be dichorionic diamniotic. If the separation occurs between day 4 and 8, it is going to be monochorionic diamniotic. If the separation occurs between day 9 and 12, it's going to be monochorionic monoamniotic. And if there is an attempted separation after day 12, that will be conjoined twins. So remember, conjoined twins always attempted but were unsuccessful in splitting after day 12. Why is it important to know when they split? This looks at perinatal mortality on the vertical axis, looking at the classification. Now remember, the perinatal mortality for singletons is 7 per 1,000. With dizygotic twins, it is 50% higher already, 12. But as we get to the di-di, mono-di, and mono-mono, notice how significantly the perinatal mortality rises. So, splitting between day 0 to 3, we have dichorionic, diamniotic, a thick membrane. With a di-di, you can see a triangular-shaped area, which we will sometimes call the delta sign, which reflects the chorion from each placenta going up into the membrane. Here it is again. With our thin intertwin membrane, one placenta, this is monochorionic diamniotic. Separation occurs day 4 to 8. When you've got a monochorionic diamniotic shared placenta, you have the possibility of twin-twin transfusion. And you can see here, these twins were both conceived at the same time, delivered at the same time, but notice the significant difference in size. One is the donor, one is the recipient. The smaller is the donor, the larger is the recipient. The donor is anemic, the recipient is polycythemic. And often, the donor will do better in the intensive care nursery. Here you can see the limited area of the placenta, which was used by the small twin, and the larger area of the placenta, which was used by the recipient. Here's what happens. There is more blood, which is coming from the donor, that goes to the recipient. And so the recipient is bigger, the donor is smaller. Because there is more blood flowing into the recipient twin, it makes more urine, and you have polyhydramnios in the one sac, you have oligohydramnios in the other sac. And here you can see very nicely, the larger recipient twin, lots of amniotic fluid. The smaller twin has so little amniotic fluid that the membrane is wrapped around it, and sometimes it looks like it is vacuum packed. We can either call this oligopoly syndrome, or because this baby cannot move, it is contained within this oligohydramniotic sac, we can sometimes call it the stuck twin syndrome. This all occurs because there is unequal distribution of blood in the placenta, and there's going to be an anastomosis. It can either be a venous arterial anastomosis, arterial anastomosis, or arterial venous anastomosis. This is the case that I had, and you can see the two umbilical cords right here. Notice the anastomosis from this cord straight through to the other one. Arterial venous anastomosis. What I like to do to demonstrate this after delivery is take the placenta, take a syringe and put some milk into it, and then inject into the umbilical cord. And if there is cross circulation, if the vessels will join, the milk which I inject into one cord will go through the placenta and will show up coming into this cord over here. And look at what's happened. Milk has been injected into here, and notice what happens on this side. The other umbilical cord gets filled up. This is indication of a monochorionic placentation. Remember, twin-twin transfusion syndrome can only occur if there's monochorionic diamniotic. It's got to be monochorionic. Now, what if you have a monochorionic pregnancy and one of the twins dies? Now we've got some potential problems, which we call twin embolization syndrome. The tissue thromboplastin from this deteriorating twin can go through this anastomosis into the other twin and cause all kinds of problems in the brain, in the kidneys. Not a good thing. Twin embolization syndrome. Here we can see a very early ultrasound, a single sac, and you can see how thin this amnion is, and two fetuses very early in the same sac, monoamniotic twins. This has to occur after day 12. Mono-mono, no intertwin membrane, separation between 9 to 12 days. One of the unique complications with monoamniotic twins is because they are swimming around in the same sac, the umbilical cords can get entangled, and you can see here, both of these babies are dead. Donor, recipient. Umbilical cord entanglement. Here's a case that I had. And this was a patient at 31 weeks gestation. We admitted her at 30 weeks, concerned about umbilical cord entanglement. And here we have the fetal monitor tracing. You can see we have the two fetal heart rates. And now we have a deceleration. What kind of deceleration is this? A rapid drop, rapid return, variable deceleration. What causes variable deceleration? Umbilical cord compression. Exactly what we were concerned about. I said, I don't like this. So we moved her to the labor and delivery. And what happened a few minutes later? Another deceleration. And this one went down to 80 beats a minute. Not happy with that. Watched her a little bit longer, even more. I said, this is it. We're going to have to deliver her. And what do you think we found when we opened up the uterus? You can plan on it. Knots in the umbilical cord. And this is a major concern with monoamniotic twins. Now you think this is bad. Look at this umbilical cord. Knots, unbelievable, and yet these babies did survive. All right, umbilical cord entanglement can only occur if there is one sac, monochorionic, monoamniotic twins. Conjoining, remember, after day 12 can only occur in mono twins. And a part of management. We're concerned about anemia, so make sure the mother is on both iron and folate supplementation. We talked about 3 times more likely to have preeclampsia. Monitor the blood pressure closely. Because half of twins will deliver before 36 weeks, we need to educate the mother regarding what preterm labor is. And if this is her first pregnancy, she's never had labor, she doesn't know what it is even like. And monitor the babies for discordance in size and amniotic fluid, twin-twin transfusion syndrome. We will do monthly ultrasounds. Here's a patient who came in and she was 31 weeks gestation. I said, how are you doing? This was her first pregnancy. No problems, fine. As I was palpating the uterus, I said, your uterus feels firm. Are you sure you're not having contractions? No, I don't think so. I said, let's put you on the contraction monitor. And this is what we found. Contraction, 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 contraction. I said, you're having contractions. She said, oh, is that what they are? Is that what? She said, oh, just I'm having some back pain. But how long have you been having back pain? About 3 days. See, she didn't perceive that this was labor, but she was in fact labor, back pain. I checked her cervix, she was already 3 centimeters dilated. So we need to educate the mother about preterm labor. All right, how are we going to deliver these babies? We arbitrarily designate that the lower twin is twin A, the higher twin is twin B. If both babies, A and B, are cephalic, vaginal delivery. If twin A is cephalic and the second one is breech, who knows? If the first one is non-cephalic, we're going to do a cesarean. But when the first is cephalic and the second is breech, you may end up delivering one vaginally and then doing a cesarean for the other one. Some women will say, well, I'd like to try anyway. So you could go either way, either a cesarean or vaginal delivery, and I will offer this to the mother. I suspect on the exam you'll be either asked about cephalic or breech cephalic. And remember, because of the overdistended uterus, we always need to be concerned about uterine atony, postpartum hemorrhage. Unusual case reported of fraternal twins sharing a placenta. All right, let's summarize what we've just said. The diagnosis is by ultrasound. If the twins are, if the genders are different, it's got to be triple dye. If there is no septum, if they're in one sac, it must be triple mono. If it is monochorionic diamniotic, we always need to be concerned about twin-twin transfusion syndrome. We will assess difference in size and amniotic fluid by ultrasound. And if it is triple mono, cord entanglement is a major issue. Conjoined trees, sequoias in California. Conjoined tulips from Amsterdam. Conjoined cherries. I don't know if these carrots are conjoined, if they're just loving each other, but there they are. And that is the end of multiple gestation.